Welcome to The Explainer. If you're a medical trainee, you know that vascular access is everything for your patients on hemodialysis. It's literally their lifeline. So today we're going to break down one of the most common options you'll see, the arteriovenous graft, how they're made, and how we manage them. All right, so here's our game plan. We're going to walk through this just like you would in a clinical setting. We'll start with the basics, what an AV graft even is, then we'll get into the planning phase, what goes into choosing the right graft, and then, super importantly, how to spot and manage the complications you're definitely going to run into. Okay, first things first. Let's really nail down the basics. What exactly is an AV graft? And just as important, when and why do we pick this option? Think of an AV graft as a surgically created bypass, or a bridge. Right? When a patient's own artery and vein are just too far apart or not suitable to be connected directly, the surgeon puts in this synthetic tube, that's the graft, to connect them. And boom, you've got that high-flow superhighway you need for dialysis to work. And that really gets to the heart of it. This is the exact scenario where the AV graft becomes your best friend. Look, a fistula using the patient's own vessels is always the gold standard, no question. But when that's not on the table, the graft is our go-to backup plan. So this is the classic trade-off, and you've got to understand this. With an AV graft, you're buying speed. I mean, some of these can be used in 24 hours. That's incredible. But, and this is a big but, you give up longevity and safety. They just don't last as long as a fistula, and the infection risk is way, way higher. So it really is a choice between getting access now versus having a more durable, safer option down the road. Right, so when do we actually pull the trigger on a graft? Well, it's really a problem-solving tool. You use it when a fistula just isn't going to work. Maybe the patient's veins are shot. Or maybe the patient's overall health is poor and they just don't have the months it takes for a fistula to mature. And of course, if they've had a fistula before and it failed, well, a graft is often the next step. Okay, so we've decided to go with a graft. How do we make sure it works? It all comes down to planning. You know, that preoperative blueprint is absolutely everything for a good outcome. Now, this is an interesting point. A graft doesn't mature like a fistula does by having its walls thicken, but the timing of the surgery is still critical. The sweet spot is about 2 to 4 weeks before dialysis is needed. Why? Because that gives just enough time for the body's tissues to grow into the graft material and anchor it down, but not so long that it's just sitting there unused, risking a clot or some other problem. Okay, this is a rule you have to burn into your brain. Preserve the real estate. We always start on the non-dominant arm, and we start as far down the arm, as distally as we can. Think of it like a plumbing system. If a pipe bursts in the basement, you still have all the plumbing upstairs. If you start at the top and it fails, you've lost everything below it. So you start distally to save those precious upstream or proximal sites for the future. So these are the heavy hitters, the configurations you're going to see over and over again in patient charts. You'll see things like a forearm loop or an upper arm street. The name pretty much tells you the whole story, where it is, what shape it is, and which vessels it's connecting. You'll get very familiar with these. All right, we've got our location picked out, so what are we actually putting in the patient? Let's pop the hood and look inside the surgeon's toolbox at the different types of grafts. Okay, get ready to hear this acronym a lot. EPTFE. That stands for expanded polytetrafluoroethylene, but nobody says that. Just know that EPTFE is the undisputed workhorse material for these grafts. It's tough, it's easy to get, and it's basically the gold standard that everything else is compared to. But here's the thing, not all EPTFE is the same. It's like having different kinds of tools for different jobs. Your standard graft needs a couple weeks to heal up, but then you've got these cool early cannulation grafts. They have a special multi-layered design that lets you use them in just 24 to 72 hours. That's a game changer for avoiding those risky central line catheters. Then there are other flavors, like tapered or heparin-coated grafts, trying to tackle issues like clotting or stealing blood flow. But honestly, the jury's still out on how well they work. So what happens when you've run out of all that precious real estate in the arms? Usually it's because the big veins in the chest are completely blocked off. This is where you might see something called a hero graft, and it's exactly what it sounds like. A hero, a last-ditch effort. It's a wild hybrid. Part of it is a normal graft in the arm, but the other end is a catheter that gets tunneled all the way past the blockage and drains blood directly into the right atrium of the heart. It's a really specialized last resort solution. Okay, so the graft is in, job done, right? Not even close. Creating the access is just the beginning. For you as a trainee, knowing what can go wrong and what to do about it is where you really make a difference. Generally, when a graft has a problem, it's going to fall into one of three big categories. You've got your flow problems, too much or too little blood going where it shouldn't. You've got your local problems. Something is physically wrong with the graft, like a bulge. And then you have the big one, infection. Let's put a number on this, because this is something you should know cold for your rounds. Infection isn't just a nuisance, it's a disaster. It accounts for about 20% of all graft failures. Let me say that again. 1 in 5 grafts that fail because of infection. So if you see an access site that's red, painful, or has any drainage, that is a big red flag. That's a surgical emergency. And here's another number that's just as high. Up to 20%. That's the incidence of something called dialysis access-associated steal syndrome, or DAS. So again, this is not some rare textbook-only complication. You will see this, and you need to be able to spot it. The idea behind steal is actually super simple. Blood is lazy. It always takes the easiest path. The new graft is like a brand new wide-open freeway, while the artery going down to the hand is like a bumpy side road. So way too much blood zips through the graft, literally stealing it from the hand. And what does the patient feel? A cold, painful, weak hand. And it often gets way worse when they're on dialysis. So when steal is really bad, there's this very clever operation called the DRIL procedure. DRIL stands for distal revascularization interval ligation, which sounds complicated, but it's not. The ligation part means the surgeon ties off the artery right after the graft, which stops the blood from flowing backward and stealing. The distal revascularization part means they then build a new, small bypass around that tied-off section to get blood flowing forward to the hand again. It's a beautiful fix that saves both the graft and the hand. You're also going to see pseudoaneurysms. These are basically bulges in the graft wall, like a bubble on a tire, usually caused by sticking the dialysis needles in the same spot over and over. Now, a small, stable one might be okay to watch, but these right here, these are the red flags that scream, operate now. If it's painful, if the skin over it looks thin and shining, if it looks infected, or if it's getting bigger fast, you have to get that fixed before it blows. And I mean that literally. A rupture is a catastrophe. Okay, last point, but this one is incredibly important. When it comes to hand pain after surgery, the timing tells you everything. It's like being a detective. If the symptoms start gradually days later and get worse on dialysis, you're thinking classic steal syndrome. If it's weeks or months later, maybe it's carpal tunnel. But if the patient wakes up from surgery, and I mean immediately, with a profoundly weak and numb hand, that is something else entirely. That is a code red emergency. And that emergency has a name, ischemic monomelic neuropathy, or IMN. This is not steal syndrome. The key clue is that the hand still has a pulse, but the nerves are completely knocked out. The nerves themselves are starved of blood. This is one of the biggest emergencies in access surgery. The only treatment is to go back to the OR immediately and tie off the graft. There's no time to wait. Knowing the difference between DAS and IMN is probably the single most important thing you can take away from this, because making that call can literally save the function of your patient's hand.